today. They asked if I would just speak for a few minutes on cystic fibrosis and pregnancy. Really, so what I did was I put together about 15 minutes worth of slides or 20 minutes worth of slides, and left a lot of spots open for discussion, because I do think this is, there, y'all know an amazing amount about cystic fibrosis. And I'm always surprised at how few physicians outside of the cystic fibrosis world know about CF and the consequences of CF. So there are a handful of us in the country, maternal fetal medicine specialists, that have worked very closely with the CF groups at these academic centers, and have become quite comfortable with it, or as comfortable as a physician can be with it. And so I'm just going to go through some of the experiences that we've had. I've been at Hopkins now for 4 years, came from UT Southwestern down in Dallas, where I spent 18 years. And so had a number of patients down there, but the CF group here at Hopkins is very involved, and is very busy. And we have a number of patients that we have co-managed during their pregnancies. And I was telling these guys earlier, I think I've had 4 new patients just in the last 3 weeks, that are relatively newly pregnant or are transferring their care from other physicians. So it is, they're keeping us busy right now. So for the next few minutes, I'm just going to talk about some genetic counseling issues, and kind of where we're at in CF diagnosis. I was going to talk about fertility issues, but that goes a little bit beyond the scope of what they asked me to talk about this time, but I certainly could talk about it in the question and answer session if y'all like. I'm going to talk a little bit about the pregnancy effects on CF, but I'm also going to talk about the effects of stressing, again, the importance of that multidisciplinary approach, and then talk a little bit about breastfeeding. And then I think my last slide are some of the research endeavors that I think we need to continue to still pursue. So this is something you guys are very, very comfortable with. The reason I put it in here is so y'all understand what we have to go to when we start thinking about how do we do prenatal genetic counseling, how do we test your baby for having potential CF. The vast majority of the disease, over 85%, is associated with only a handful of abnormality or a handful of mutations. The majority of those are the F508 deletions. So if we know the deletion, we can then test the baby. So what we do is we offer fetal testing if we know the parents are carriers, or if we know the parents are affected by cystic fibrosis. So if we know the deletion, we can do the testing. We can also test for the most common deletions known, but as you can see at the top, there are over 2,000 CFTR variants identified. So there's always going to be a small percentage that we are still unable to test for. So if you happen to be carrying one of the unusual mutations or less common mutations, it gets a little bit more difficult to test for. We also test babies that have fetal abnormalities consistent with cystic fibrosis. I put one of them up here, this ultrasound picture that y'all see on there. There is an echogenic bowel. I don't know if you can see my cursor circling around it, but there's a little white arrow there pointing to it also. So bowel should be kind of darker. The areas that are what we call echodense or echogenic are the whiter areas, the ones that are bone, things like you can see the spine there, you can see the head on the right-hand side, but you also can see an area of bowel there that is white, more consistent with what we see in the lung fields here. And we call it bone bright. And something like that makes us a little bit more concerned that the baby may end up having cystic fibrosis. So even if we don't know parental carrier status, if we see that, we oftentimes offer at least parental carrier testing. And I just wanted to mention the ethics of this at the bottom, because this is actually an area of research that I think is important is, what are the ethics behind identifying, a baby with CF, particularly if the parents are carriers. It's important from a clinical standpoint, but there is also the conversation that has to be held of, is the testing going to be a false negative? Or there's rare false positives, but could the testing be false negative when we not identify it? If we identify it, what are insurance consequences? What are long-term consequences? So I think the social aspects of identification early on of a fetus with CF is an area that still needs a little bit more research. But I still think I personally think it's incredibly important to identify early. So I wanted to talk a little bit about pregnancy, because pregnancy really does have an effect on patients with cystic fibrosis, particularly those that have more of the respiratory sequelae from cystic fibrosis. So what happens in pregnancy? Just anybody that gets pregnant, over the course of the 40 weeks, the diaphragm starts to rise, and it actually increases by it rises up about 4 centimeters. So you no longer have the ability to expand your diaphragm quite as much. So you start just, feeling, again, anybody will start feeling a little bit more short of breath and not be able to handle, walking up as many stairs as they used to be able to and such, because they just can't catch that deep breath. There's also, even though the respiratory rate doesn't really change much, the amount you can breathe in at a single minute kind of changes. The tidal volume increases by about 50%, but what we call the functional residual capacity, so what is left in the lung after you expire, actually goes down quite a bit. And I think I have a slide here that just talks about the left-hand side is non-pregnant and the right-hand side is the pregnant. And you can see things like how much air is left in the lungs. That expiratory residual reserve volume actually goes down in pregnancy compared to non-pregnancy. And how much functional residual capacity you have left total goes down in pregnancy as the diaphragm elevates. So respiratory complications are a little bit greater in pregnancy. It's also one of the reasons why patients are a little bit more likely to get pneumonias, is because they can't clear secretions quite as easily. The other thing you have to think about, everybody always thinks about the lungs and cystic fibrosis, but the other thing you have to think about in pregnancy is we increase our blood volume by about 30 to 50%. So when, a normal, a non-pregnant individual may have a blood volume of about 3.5 liters, but when they become pregnant, that may increase up to about 5 liters or so. So in a patient with cystic fibrosis who has a history of pulmonary hemorrhage, the chance of a pulmonary hemorrhage occurring during a pregnancy may actually go up quite a bit with it, because the blood volume increases so much. It's one of the reasons why nosebleeds in pregnancy increase. Even in the patient that's never had a nosebleed before, a lot of patients will suddenly develop horrible nosebleeds in pregnancy because of that increased blood volume. Now, evolutionarily, the whole reason we do it is because pregnancy is pretty bloody business. So you deliver your baby, you end up dropping, 0.5 liter of blood at the time of delivery. Well, your body has over the course of the pregnancy increased the blood volume by enough that, patients survive pregnancy and survive delivery. Unfortunately, it has some consequences for patients with pulmonary diseases such as cystic fibrosis, who may have an increased risk in pulmonary hemorrhage. So I wanted to put this in here. This is, you guys have probably all seen this. This is out of the CF Foundation Patient Registry Report. These are the 2018 numbers. That's the last one I could find so far. And the first arrow just says people with cystic fibrosis. And you can see the big increase in the numbers from 2003 until 2018. And when you look at that second arrow, adults over the age of 18, you'll notice about 55% of CF patients recorded in the registry are adults, so they're reproductive age persons, and almost half of those, the last arrow, almost half of those are going to end up being female, about 48.2%. So significant number of reproductive age females out there, and oftentimes, as you guys know, people are living longer. They are much healthier on the different medications that are now out there. And so there's a lot more interest in pregnancy. So this is what the registry has reported from 1998 up to 2018. You can see a doubling in the number of pregnancies from 98 to 2018, just over those 20 years. So this is kind of what we're seeing right now is, we have a number of patients every year that are pregnant. In 2018, they had 280 reported to the registry alone. So this kind of gets into the importance of the multidisciplinary team. So we're having increasing numbers of patients, and it is incredibly important for the cystic fibrosis team that you have to be involved. But I also want to put a huge plug into when a patient does become pregnant, or frankly, even before they become pregnant, if they're thinking about pregnancy, meet with a maternal fetal medicine specialist that knows something about cystic fibrosis so we can optimize you before you become pregnant, and then take care of you as you're going through the pregnancy. I think that nationally we've become very good about this multidisciplinary care concept. You'll notice from 2008 to 18, just over 10 years, we've been much more likely to get social workers and dietitians and respiratory therapists involved in the care of our patients. So if you're thinking about pregnancy, add a maternal fetal medicine specialist to that team. One of the big reasons why you want to do that is cystic fibrosis patients are on a whole lot of medication, and they have been throughout their life. And that doesn't suddenly stop because they become pregnant. You know, the last thing we want is for patients that are stable on medications, doing great, they get pregnant, and then they stop all their medications because they're scared about the effects on the baby. That's the last thing we want. We actually want you to stay on medication, but stay on medications that are considered safe in pregnancy. So what we do is I work very closely with the CF team. When one of our patients becomes pregnant, we go through all of their medications. The good thing is the CF team I work with here now, by the time they call me, they've already, they know all the medications that are good in pregnancy, but anytime they're thinking about adding something, an antibiotic, or a pulmonary enzyme, a pancreatic enzyme, whatever they may end up adding, they usually end up bouncing it off me, and vice versa. If I have to add something for the pregnancy, I bounce it off them first. So we do a whole ton of risk-benefit discussions. This medication may be safe in the second trimester, but not in the first trimester, or it may be fine in the first trimester, but not 4 weeks before delivery. So there's a lot of back and forth on the different medications. We do know that pancreatic enzyme replacement is acceptable. Most of our patients are on that. The antibiotics are where we get into, there may need to be some dose adjustment. There may need to be some trimester adjustments. And a lot of the antibiotics that we knee-jerk say, oh no, you should never use in pregnancy, that we use a lot in cystic fibrosis, we actually can use in pregnancy. We may just have to do some adjusting. Corticosteroids, people are always a little hesitant to start those in pregnancy, but inhaled corticosteroids and oral corticosteroids are perfectly acceptable in pregnancy, so we do a lot of counseling about that. There's a lot of the inhaled medications for airway clearance that we talk about, but the vast majority of those are just fine. A lot of our non-pregnant patients are on NSAIDs for the anti-inflammatory effects. Those we're not as thrilled about in pregnancy. We try to avoid particularly the things like aspirin and Advil, or I'm sorry, not aspirin, but things like Advil and some of the other non-steroidals. We do avoid those in pregnancy. I wanted a slide on this one because so many of our patients now are on the CFTR modulators, the single modulators, the combination modulators. I think the vast majority of my new patients have been on Trikafta lately. I'm not pushing one drug or another, but these medications have really changed a lot of our CF patients' lives. There is a paper that just came out in March of 2020. So before this, there was very, very limited data on these medications in pregnancy. This paper that came out March of this year, it's not a huge paper, it's not huge numbers, but what they did was they took everything that was out there, data regarding these medications, and looked at safety data, and there were no significant concerns identified. The main thing, because of the use of these modulators, is it may affect when the neonates get their immunizations up to about 6 to 12 months of age. The pediatricians have no problem with this. They just need to know that our patients are on this. I have seen some incredible complete turnarounds in patients' response to pregnancy while on these medications. So I am a firm believer in keeping them on if they are doing very well. But again, that's a big discussion. Every time I see a new patient, the CF team and I kind of walk through all the different medications. So what are the effects of cystic fibrosis on the pregnancy itself? So if you've got CF and you get pregnant, what are the chances of having bad outcomes in pregnancy? So we know that miscarriage and stillbirth is slightly higher, and I do mean slightly. We used to think it was much higher, but the most recent or contemporary studies have not shown that to be true. So the risk of miscarriage is just a very little bit higher than the general population, same with stillbirth. Prematurity rates used to be reported well over 25%. Now prematurity rates are reported mainly at 10 to 25%. A lot of this, though, is predicated on your pre-pregnancy respiratory function. So if you have an FEV1, and the FEV1 is the one that we usually look at for how well they're going to do regarding prematurity and other pregnancy complications. If you have an FEV1 of over 75%, there is very low morbidity. I spelled morbidity wrong, I just realized that, and mortality. So most patients with FEV1s that are significantly elevated, like over 70%, do very well in pregnancy. The 50 to 70%, really, they only have a mild increase in complications. The ones where we see a definite increase in prematurity rates, possibly growth issues, are the ones that have FEV1s less than 50%. But I can tell you, if I have somebody that starts off the pregnancy at 45%, but they've been stable at 45% for several years, most of those patients end up doing pretty well. So stability over time is actually another important factor. But that 50%, one paper uses 60%. I usually use somewhere around 50%. If they're less than that, we do sit down and talk quite a bit about some of the potential complications for the pregnancy. The good thing is we know that, for the effect of cystic fibrosis on the pregnancy, there really is no increase in congenital malformations above baseline. There may be an increase in fetal growth restriction, but that is usually associated with baseline hypoxemia. So if you have cystic fibrosis and you're on home oxygen and your FEV1 is 35%, you are much more likely to have a preterm delivery, have fetal growth restriction issues than, say, somebody who keeps her SATs at 98% on room air with an FEV1 of 80%. So we do a whole lot of counseling based on what the baseline numbers are. And that's one of the reasons why I believe that patients should come in for preconception counseling, because we want to be able to talk to you and optimize your care before you ever become pregnant. So what are the effects of pregnancy on cystic fibrosis? So instead of the reverse, what happens on the effects of pregnancy on cystic fibrosis? Well, if you've had pulmonary hemorrhage before, because of that increase in blood volume, you may see an increase in pulmonary hemorrhage risk during the pregnancy. If you've had borderline OGTTs, for a while there, the placenta produces a hormone that increases your insulin resistance. So if you're knocking on the door of diabetes, it may tip you over the edge to a gestational diabetes type phenomenon. And if you're diabetic, you may be a little bit more difficult to control during the pregnancy, but that's fine. We work with the endocrine guys and we adjust insulin and such as we need to. And then there is the risk of increasing pulmonary exacerbations during the pregnancy. Again, a lot of that is because of the increase in the diaphragm, not being able to clear secretions as well. And we do sometimes see an increase in the infection risk and also just deterioration of lung function. And we'll talk a little bit about long-term consequences, but those are kind of some of the short-term or immediate consequences. We do counsel patients if they have bad pulmonary hypertension or cor pulmonale, we consider that a contraindication of pregnancy because of maternal morbidity and mortality increases so much in that scenario. So long-term effects, the early reports, so 20, 30 years ago, reported on long-term consequences of patients with CF that became pregnant. They may have long-term deteriorated lung function, or if their lung function worsened during the pregnancy, it didn't rebound completely. However, more contemporary studies have actually noticed very similar health trends as a non-pregnant female. So, 20 years ago when I was taught, we always said, look, if the lung function deteriorated, say you went from an FEV1 of 60% down to 40% during the pregnancy, you may never reach that 60% again. But a lot of our patients actually do eventually get back up to their pre-pregnancy lung function. A lot of that has to do with some of the newer medications that are out there. And then the other thing I wanted to mention, and this is actually a big deal, the physical and emotional demands of raising a kid have to be taken into consideration when you're thinking about, pregnancy with cystic fibrosis. It's exhausting. And so having a kid, both the physical and the emotional strains are really impressive. And it's hard to explain that to somebody until they've actually had a child themselves, but it's exhausting. So if you're having issues with your own health care, you do have to make sure that you've got the resources or the help at home to help with the demands of a new child. So let's talk just a little bit about management in pregnancy, and then I'll finish up. But management in pregnancy, we always make sure the partner is tested if they're available. Nutritional counseling. We have the CF nutritionist at Hopkins. I know well. We email each other on these cases, because you do have to increase the caloric requirements, about 300 kcals a day. And as you guys know, it is hard to get weight. It's hard to maintain weight in a patient with cystic fibrosis. And here we are asking you not only to maintain, but actually we want some weight gain. I'd love to see 25 pounds. That's kind of my pie in the sky. A lot of my patients don't gain that much, but that is our goal, is to increase kcals about 300 a day and try to at least get some basic weight gain in. We do supplement vitamins A, D, E, and K during the pregnancy. I already mentioned the diabetes. We do early OGTTs, and again at 24 to 28 weeks. Diabetes can be a little bit more difficult to manage during pregnancy, but we work with the endocrine guys and we're able to do it. We do a lot of breastfeeding discussions. So a lot of our patients, want to breastfeed. It is fantastic to breastfeed. However, you have to increase your calories about 500 a day to be able to maintain breastfeeding. And a lot of our patients with cystic fibrosis, that is not an option. So I start talking breastfeeding very early on in pregnancy, because I don't want people to be frustrated or think they are failing if they can't maintain their calories and they can't breastfeed. The other thing is some of the medications oftentimes that CF patients are on are not compatible with breastfeeding. Some are not. So we also talk a lot about the medications they're on. And then I did want to mention this enzyme replacement is usually safe in pregnancy. We do monitor respiratory status very carefully throughout the pregnancy, where we watch those FEV1s. We have a very low threshold for admission. I know you guys, a lot of patients are used to, home antibiotic therapy and all that. During pregnancy, I'm fine with that, especially early in pregnancy. But as you get a little bit further along, we're much more likely to admit you to the hospital. I admit, frankly, after 20 weeks, I usually admit patients to my ward, and the CF guys come up because we want to manage the pregnancy and the CF. Home oxygen therapy is not a failure. If we'd like to keep our patients with saturations above 95% or greater than or equal to 95%. So I've started several of our patients on home oxygen, and they have done very well. So it's not a failure. It happens occasionally. Most patients don't need it. And then I already mentioned, we'll be watching you guys for fetal growth restriction, stillbirth. We'll be doing ultrasounds. We'll be doing fetal monitoring as you get through the pregnancy. I have OB anesthesia talk to you. Vaginal delivery is a goal for our patients with cystic fibrosis. If we can put an epidural in and have a great little vaginal delivery, that's perfect. If we have to go to a C-section, we still like to do those under epidural. But if we have to do general anesthesia, I really want OB anesthesia aware of baseline pulmonary status. So I get them involved early, about 28 weeks. And then if some of our CF patients have had lung transplants, that is not a contraindication to getting pregnant. There have been a number of case reports. I think the registry reported, 21 pregnancies of patients that have had lung transplants, and it is doable. It just requires a little bit more intensive management, because you're also now dealing with the transplant team and different medication adjustments that need to be made. But it certainly is not a contraindication to pregnancy. We can do it if people are interested. So I'll finish up. I think that's about 20 minutes or 25 minutes. So I'll finish up just with basic research endeavors. I think a lot of the data we have in pregnancy comes from the 70s, 80s, 90s. We have a whole lot of new medications out there. We are much better at managing respiratory and secretion clearance. We understand the social implications so much better. And we do now have a number of patients that have had lung transplantations. So I think more contemporary outcome data has been very helpful, particularly from the CFReSHC data. And then these new medications, we do need to know pregnancy. Oftentimes, if you are stable as a rock on a certain dose of medication, pregnancy with the increased blood volume and the increase the renal clearance, the kidney clearance, and all these medications, there may be some dose adjustments that would help, and we just don't have a lot of data about that in pregnancy yet. So for right now, I think we need to get more drug information also. And with that, I will finish. And I don't know how you want to do it. I don't know if you want to open it up for questions or comments. I mean, I'd love to hear stories too.